start. Probably a few more people will join later, but I will make a head start with our educational session on ultra-low field MRI. I really want to welcome you all because I think it's also one of the first educational OHBM sessions on this neuroimaging modality. So today we'll really talk about ultra-low field MRI, and more specifically we'll give presentations where we use the hyperfine swoop scanner, which is like 64 millitesla. So yeah, the question that I actually get a lot the last months and the last year from colleagues actually is like, why, Karen? Why did you move into this dark side of ultra-low field MRI? Why did you decide to go from these high-field, crisp, high-res images to these really fuzzy images using ultra-low field MRI? And especially with my work that I've been doing in patients with brain injuries. And the answer to that question is actually the clinical reality. Like, there are actually many hurdles in the clinical practice of TBI patients. So for example, in one of our recent studies, we administered a survey in health professionals that are working with patients that have sustained a traumatic brain injury. And I was really interested to examine to what extent are MRI scans being used in the clinical practice. And we were especially interested to what extent are both conventional MRI scans used, but also to what extent are advanced MRI analysis being used in this clinical setting. And first of all, some exciting results where, first of all, there's some positive news. So actually the majority of health professionals, more specifically 73%, they did indicate that they are using or acquiring MRI scans in TBI patients. However, there's still a quarter of health professionals that are not acquiring MRI scans in TBI patients. And we were really interested to see what are the reasons for not administering MRI scans. And actually one of the main reasons was the availability of the high field MRI scanner, and then I really mean with high field 1.5 Tesla or 3 Tesla, was not available for these TBI patients. Another result of this survey study was that, and I think this is a really important result for the OHBM community, is that less than half of the health professionals indicate that they perform advanced MRI analysis. So only 42% of health professionals are performing advanced MRI analysis. And I think this is something that we as the OHBM community can do something about it. Again, within our survey, we were really interested to see, okay, what are the factors that would help the clinicians to increase this uptake of advanced MRI? And the two factors that they were really raising was that they need more user-friendly tools to perform these advanced MRI analysis. But secondly, they also highlighted that they need more dedicated researchers within the clinical team. So I really think that we should use more ultra-low field MRI to overcome these technical and practical issues with high field MRI. On a second note as well, I'm going to give the word to one of our patients that we have scanned in one of our previous projects. So this is Raquel. So she sustained a mild traumatic brain injury or a concussion because she was hit by a car. And I really want to share this story because I think it's very powerful. And I think it's also something that we should be doing more as neuroscientists. We should listen more to the patients. What do they experience and what is the clinical reality? So I will really give the word to this patient, and I hope you can appreciate for her sharing her story.
So I believe, and it is hard to recall, and usually I've got a good memory, but I believe I went from a bed to another room and another couple of doctors saw me. And it was just I guess the preliminary tests of what happened, where you saw, and I was playing it down because I didn't really know. I just hit my head, I'd been hit by a car, felt like an idiot. But I was sick. I felt really sick and off balance, vertigo. But I'd had the injection. It was starting to work. I think they'd given me some tablets as well, anti-nausea at my request. And I remember a female nurse coming in, and she did okay, I want you to follow this. I want you to follow this. And I did that. And she said, what's your name? What's your date of birth? What's your phone number? And all the sort of that long-term memory recall. And then she said, what day is it today? And I didn't know what day it was. And I thought, is it Saturday? Is it Sunday? Is it Tuesday? But it can't be Tuesday. And then I burst into tears. And I said, and she said, why are you crying? And I said, I don't know what day it is. And I said, but I know I should know that. And she said, you've got a concussion. And she said, this is normal for a concussion. But I was really distressed because that's something I should know what day it was. I had no idea. And I was quite emotional, and I can't recall completely. I definitely did not have an MRI, but I believe I may have had a CAT scan. But I feel like there was some discussion back and forth with the clinical practitioners, the nurses and doctors there, whether or not I should have a CT scan or not. I believe I did have one because I probably was quite distressed and yeah, and I think their ultimate decision was that I would, because I do remember going into another room, but it wasn't an MRI. Or maybe it was an X-ray. I think it might have, actually it was an X-ray to see if I had a skull fracture. I didn't. So they said, look, your results are clear, you don't have a skull fracture. I remember thinking I wanted something to show up because I knew something wasn't right. And I said, what happens if, and they said, look, you know, your skull, like you've got a concussion, you know, with concussions, they're just going to go over time. You've knocked your head hard. They explain what a concussion is. It's the brain and the fluid, and it's just that bang. But that was sort of preliminary. I knew that, I already kind of knew that from a child when my mother explained it to me when my brother had one. So it wasn't really clinical, or I guess it wasn't really in depth. But they explained it to me. And then I said, well, what happens if I'm sick again? What if I can't balance? And what do I do? And what do I need to do? And they said, look, you'll get your discharge notes and we'll send your discharge summary to your GP. But I said, but I want to know, like, what do I do now? Do I need scans? And they said that your GP will determine whether or not you need a CAT scan or an MRI and the next steps. But I knew I wasn't right. And I said, but what if I'm sick again? What about when this injection wears off? Can I come back? Can I have a script? And I think I asked for a script of Endone or something like that, or the anti-nausea. And they said no, they didn't write me a script. And I remember being upset about that because I was scared I would go back to that wobbliness because it was Sunday and I had to work the next day, and I thought, I don't want anyone to know what's happened. I just want to be normal. And I knew I was far from normal. So I was discharged. I wasn't formally admitted. I guess I was just discharged after that assessment, and I was discharged with the clinical note, with the discharge summary going to my GP. No script, no hospital follow-up.
So yeah, I hope you really enjoyed and appreciated the story of this patient, because she was really willing to open and talk about all these details, what happened with her when she was at the emergency department. And this is, again, something that I really feel like within our OHBM community, I feel like there's becoming this gap a bit with what we're doing within our field of cognitive neuroscience and the clinical practice. Like within our field, we are really focusing a lot of attention on advanced MRI analysis and really state-of-the-art scan sequences. And all these developments are very interesting, but we really need to try to close that gap a bit with the clinical practice, because as you have heard from this patient, there's really a lack of imaging. And I think, again... And I think, again, one of the advantages is hopefully we can use ultra-low field MRI to close that gap between neuroscience and the clinical practice. Because here on the slide you can see several advantages. Of course, we start first of all, it's lower scanning strength. So today we'll really talk about these 64 millitesla scanners, but it really weighs much less than the high field MRI scanners. The applications are a bit limited with ultra-low field MRI. Of course, with high field MRI, we can scan the whole body. However, in this stage with ultra-low field, it's mainly the brain and the extremities as well. The price tag is, of course, very hefty for a high field MRI. I think we're really talking about 1 million at least per Tesla. While with the ultra-low field MRI, the price tag, I think it's still very hefty. It's below $500,000. But I hope, again, in the future that will maybe become less of a hurdle as well to purchase for the clinical practice as well. Again, for high field MRI, we really require, as you all know, we really require a lot of infrastructure. We need a cryogen, we need a specific shielding room, we need all these highly trained technicians. Well, for ultra-low field MRI, we actually just need a small room and we need a bed. The power requirements, again, a whole issue for high field MRI. I really found this amazing comparison of another presenter last year where they compared it with high field MRI, almost requires the power of a submarine compared to the ultra-low field MRI, which you can just use a standard wall outlet, like for a coffee machine. And I must say, I do prefer my coffee machine compared to a submarine. The safety requirements, as we are all familiar, we really need to do a lot of safety screening before we do high field MRI. While recent ultra-low field MRI studies, especially in the emergency department, they really have shown reduced interaction with metallic implants. And as you can imagine, in terms of portability, high field is of course not portable at all. And they really say ultra-low field MRI is portable, but I really want to highlight, I would say, I would put it in quotes as well, that it's relatively easy to transport. Because Juan and myself, we had a discussion yesterday as well with Professor McMahon, and she really indicated, like, it is easy to transport, but within a site. So it's easy to transport, for example, from one room to the emergency department within a site, but hopefully, again, with future developments, we can maybe transport it maybe even easier between sites. And we'll also have a talk from Sean Dioni later that will show some promising work about that topic as well. In terms of accessibility, on this slide you can actually see a figure about the availability of MRI scanners across the world, and I hope you can appreciate as well. But there's a really global disparity in the availability of MRI scanners. And the gray colors actually indicate no availability of MRI scanners, and the yellow color indicates only few MRI scanners are available. So yeah, you can really see that there's this high disparity. And again, I feel like with ultra-low field MRI, hopefully that provides more opportunities to really provide equal access to neuroimaging. But, of course, a big but, we're always very excited about a new technique, but then we're immediately aware of all the different disadvantages. So with ultra-low field MRI, of course, there's reduced SNR, there's reduced resolution, which actually often obscures the clinical pathology as well if you're working with patients. Then there's the issue of increased acquisition time. It takes longer to acquire your scans on an ultra-low field MRI scanner. There's also the differential contrast, which is due to the T1 shortening, and again, that may mask the clinical pathology. And then last but not least, there's really like this reduced repertoire of different scanning sequences. So yeah, of course, there's no possibility yet for doing fMRI, ASL, MRS, and so on. But again, with our educational session, we'll really show you some solutions. So there will be some talks about how can we improve the SNR and the resolution. But also we will have an interesting talk from Derek Jones, who will really show that diffusion MRI is possible, even tractometry. So just a quick overview of the learning objectives. So today I really want to give like a whole overview of what are the unique opportunities, but also what are the challenges associated when you are doing MRI with ultra-low field MRI. Secondly, we'll give you a few post-processing strategies to really improve SNR and resolution of low field images, especially with machine learning. And then last but not least, we'll really give a whole overview of applications of ultra-low field MRI, both in patients with brain injury, but also in low-income countries. On this slide, you can see the different talks that we have for today. So first of all, Associate Professor Chen will give an overview of ultra-low field MRI and the data processing. Then we'll have Professor Jones talking about this exciting tractometry using the fusion MRI at 64 millitesla. Then we'll have Professor Parizel, who will give a talk about ultra-low field MRI in stroke patients. He will really share his first clinical experiences. Then we'll have a talk from Professor Dioni, who will talk about this application of ultra-low field MRI in these low-income countries, including Africa and South Asia. Then we'll have a talk from Dr. Dominguez. He will give an overview of our project that we are currently running in patients with brain tumors and stroke patients. Then we'll have a talk from Dr. Islam, who will talk about ultra-low field MRI. How can we improve this SNR using machine learning? And then last but not least, we'll have a talk from Professor Law. Because OHBM is now in Australia, we're really happy to actually share our Australian NIF ultra-low field MRI network. And then last but not least, we'll have a session with really concluding remarks and some longer Q&A session. So just to finish off with some practical notes, please feel free to ask questions. So after each presentation, after most of the presentations, we'll have an allocated time of 5 minutes where you can really raise your hand and ask questions. And then also we'll have that long concluding section where we can really brainstorm and take on more questions. If you're not willing to raise your hand or go to the microphone, please participate in this Q&A session via the OHBM app. So if you haven't downloaded this app, please download this app. I will try to moderate this session as we go. And then last but not least, and this is for all the educational sessions, you can really submit your evaluations at any time during an educational session by using this audience response button in the OHBM mobile app. And then last but not least, please feel free to email me as well if you still have questions afterwards. And then without further ado, I really want to ask Associate Professor Chen to come to the stage, and then I will introduce him as well.